All right, good afternoon, everyone, or morning, depending on your time zone, and welcome to today's webinar titled Navigating the COVID-19 Billing Guidelines to Ensure Regulatory Compliance. We appreciate you taking time out of your busy schedules to join us for this 60-minute web session. Before we begin, let's cover a few housekeeping items. All attendees have been placed on mute in order to eliminate background noise. We encourage you to interact with our speaker throughout the presentation by typing your questions and comments into the Q&A panel. Your questions will be answered following the presentation as time permits. We may not get to all of your questions live, but we will be providing you with an FAQ document with the questions and answers received throughout today's session, as well as the PowerPoint presented, and a link to the live recording within 5 business days. May I reiterate, within 5 business days, you will receive an email with an FAQ document with the questions and answers received throughout today's session, as well as the PowerPoint presented and a link to the live recording. Today's presenters are Jennifer Bishop, Vice President of Content, and Ardith Campbell, Content Product Manager here at VitalWare. Jennifer, the show's yours. You now have the floor.
All right, thanks so much, Julie. Welcome everybody, and this is a mouthful of a webinar because these are mouthfuls of changing guidelines. So I know that some of you are going to have questions that we're not going to get answered immediately here, but please send those questions in. We'll make sure we research them and get them back out to everybody. So let's jump in here. Quick reminder that this is current at the time we are presenting it, but these things are changing sometimes hourly, definitely almost daily. So we are going to make sure that we keep you guys informed through vital alerts and stuff of changes. All right, so let's start on this. We've done a couple of webinars over the past couple of weeks that are focusing more on the coding. This is going to focus more on the billing and reimbursement and some of the temporary measures that CMS has put in place. So I'm going to start with the essentially facility perspective, and Ardith is then going to take over on the professional or physician perspective of things. All right, so remember, we're talking outpatient hospital scenarios here. We're getting a lot of questions about how do you bill for specimen collection. So I put together a couple of scenarios here. Scenario number 1 would be the specimen is collected during the course of an E&M visit. So the patient presents to the emergency department or a hospital-based clinic and has an E&M visit as well as has a COVID specimen collection. In that case, there is no separate charge for that. The collection is already included in what you're going to bill the patient. Scenario number 2 is the patient is coming by just for specimen collection. And in that case, because CMS has deemed that this does take some skill to get an adequate specimen here, you can actually report a low-level clinic visit. And I just stuck the reimbursement there for you just in case you're wondering what that would be for that low-level clinic visit. All right, here's the new codes for COVID-19 testing. I'm not going to spend a lot of time on this. These are new, but now they're not new anymore, really. We've been dealing with them for a while. But we have 2 U codes and a code released by the AMA. So again, we're getting questions all the time about, well, what's the difference on these? When would I use these? So the HCPCS codes are split into CDC and non-CDC. The AMA code is not specific to that, although it is specific to the testing methodology of amplified probe technique for nucleic acid. And the question one of the questions I think I've gotten the most is, well, which of these do I use and who's going to pay me for what? So, of course, that is the payer's decision, so I can't tell you blanket across which one to use. I can tell you that these are the guidelines that have been published, and that as we look at it right now, particularly from those commercial payers, most places are going to allow either the U code or the 876 code, just in order to make things easier for hospitals. Note that these have a little different effective date, and they all are accepted on or after April 1st, which just means that the payers needed some time to be able to accept those codes on the claims. Okay, probably second biggest question, maybe even first, is telehealth. How do I bill for telehealth? All these regulations have been relaxed now. I see there's some additional services. How do I, as a facility, again, remember we're talking about facility, bill for telehealth? And we just want to reiterate here that there's really not a facility fee for telehealth. When you're providing telehealth services, it's really the physician that is doing the work, or I say physician broadly, it can be other non-physician providers, and Ardith's going to go more into that. But basically, the only cost to the hospital for a telehealth service for the patient that's not sitting there in the hospital is really things like maybe the iPad that's being used, the internet connection. None of that stuff is directly chargeable to a patient. It's all part of overhead costs. So let's look at some scenarios for the telehealth. Scenario number one would be your physician is in the hospital and he's providing telehealth services to a patient that's home. There's no facility fee for that. The physician would be billing for that. Scenario number two would be the physician is actually at home and is providing telehealth services to a patient in your hospital. And in that case, you can bill the originating site facility fee because the patient is in your facility. Other than that, I know it's not great news, but there really isn't much cost to telehealth for a hospital. So, anybody feel like their hands have had to join a 12-step program? I know I do. All right, so let's just take a look at the inpatient reimbursement, because again, this is something I've gotten frequent questions on. You know, what happens when I code the COVID-19 stuff? So first of all, I just put up here a little graphic for you on the implications of the MS-DRG grouping. I found it super interesting that they've got DRGs for if COVID is basically your primary and causes respiratory conditions. They have DRGs for COVID in newborns, and they have DRGs for COVID in HIV patients. They did not assign COVID to anything for the OB at this point. I'm kind of expecting them to correct that, but right now COVID would not impact an obstetric patient. From a DRG perspective, of course it would clinically, but DRG is what I'm talking. All right, we're also getting lots of questions about what do I do if I have to keep a COVID patient? They may be quote unquote recovered and not need inpatient care anymore, but what happens if I have nowhere else to put them? They still need to be quarantined, or there's nowhere else essentially to send them that's safe. And Medicare has said that they're going to pay for the entire stay. They're going to include outliers, if that's appropriate, for those patients who may not meet medical necessity to still be hospitalized, but need to be hospitalized because they have to remain quarantined. They also said that you should not be charging a differential for a private room for these COVID patients that may require to be quarantined. So they're going to pay for it, but you can't charge them more for a private room. There's also a waiver, a temporary waiver right now of the 3-day prior hospitalization rule. So basically what that means is that the patient doesn't have to have 3 days of inpatient hospitalization before they're going to have SNF care covered. That's, as with all of these waivers, that's temporary. Kind of remains to be seen how long that's going to be in effect. Typically, these waivers are done 60 days at a time, and they will essentially cease as soon as the public health emergency is over. But of course, we don't know right now. All of these waivers basically are retroactive to March 1st that I'm going to be talking about. So just wanted to real quickly throw something in on the accelerated and advanced payments. We're getting some questions about that. How do I get them? What do I need to do to get them? So you can see if you're a Medicare Part A or B supplier, you may be eligible. There's a little more detail on the next page. It's basically a temporary measure to increase the cash flow for hospitals. This money does have to be paid back, but it will increase your cash flow temporarily. It's going to be allowed for the duration of the public health emergency. And the big one, where do you apply for this? Every MAC has their own request form. So go out to your MAC's website and you'll be able to apply for that there, if you meet these eligibility requirements. So you must have billed Medicare within 180 days prior to the date of the signature on the request form. You can't be in bankruptcy. You can't be in active medical review, and you can't have any outstanding delinquent overpayments to Medicare. I know I'm moving fast here, but we have an awful lot of ground to cover. So remember, you can always reach out with questions. All right, so I wanted to quickly go over the flexibilities that CMS is allowing under the blanket 1135 waivers for the duration of this public health emergency. They're divided into 3 basic sections. So our first one is called the hospital without walls. Basically, in a nutshell, that's going to allow hospitals a lot more flexibility to provide patient care in temporary expansion sites, although the location has to be approved by the state. It's going to allow COVID-19 patients to be screened off-site. Basically, they're waiving enforcement of EMTALA waivers. Any location meeting the conditions of participation has the flexibility to operate to meet hospital needs. So basically all that means is you're not quite as sectioned off anymore as far as, okay, I have to have emergency patients in my emergency room. There's a little more flexibility there. And there's a lot of flexibility with your inpatients and other patients of distinct care units like psychiatric and rehab patients, long-term hospital patients. You can mix and match essentially a little bit more than you can normally, just to try and meet the needs of space. For critical access hospitals, there's been a waiver of the 25-bed limitation. The 96-hour length of stay limitation has been lifted. The rural requirement for critical access hospitals has been lifted. So that doesn't mean that all of a sudden everybody's a critical access hospital. That just means that if you need to provide testing at an offsite location that may not meet the rural criteria, you can go ahead and do that. And there's been some waiver of provisions related to telemedicine to allow for increased access to care. Remember, again, that doesn't mean that there's still a facility fee for telehealth services in most cases. It just means that patients don't anymore have to be in specific locations. Okay, the second part of the flexibilities is in the patients over paperwork. So there's some flexibilities around verbal orders. There still has to be readback of verbal orders, but they don't have to be authenticated quite as quickly. Some reporting requirements in regards to soft restraints, some lifting of the discharge planning requirements. So you don't anymore have to provide patients with all their options for post-acute care discharge. Just trying to make sure we're focusing on direct patient care as opposed to some of these other things. There's some flexibility in completion of medical records requirements. And again, the advanced directives, it's not a requirement right now that you ask every patient about their advanced directive plans. There's also been some extensions as far as filing requirements with regards to the quality, the occupational mix. The individual nursing plan requirements don't have to be so strictly documented. Utilization review, there's a temporary waiver on the utilization review plan, and the UR committee, there's not going to be, nobody's going to come back and ding you for that right now during this particular time. And as far as the surge sites, there's some flexibilities there. You don't have to have all of the documents in writing at the surge sites that you do for your hospitals. And there is an extension of cost reporting. There's probably not many people on the phone that really care about the cost reporting, but if anyone asks you, that's been delayed as well. In the home stretch here, let's see, we have a waiver of the sterile compounding requirements. Basically, it'll allow nurses to reuse protective, and I say nurses, I mean more hospital staff than that, to reuse protective equipment. Physicians that may have their privileges about to expire don't really have to worry about that right now. They don't have to undergo medical staff review. There's some more flexibility as far as patients not needing to be under the care of a physician. It could also be a physician's assistant or a nurse practitioner. Some flexibilities around the CRNAs. Supervision is going to be at the discretion of the hospital and state law now. And respiratory care. The personnel that are qualified to perform respiratory care, there's some relaxing of those restrictions and also some supervision requirements. I ran through that as fast as I possibly could, and I am now going to turn this over to Ardith to talk about the physician piece.
All right. And if you want to go ahead and move to the next slide, Jennifer, we will start talking.
So cute.
We'll talk about claim submission. Now, the condition code DR for disaster related, of course, is for hospitals, and that should be used when all items on the claim are related to the disaster. And then we also have modifier CR, which is your catastrophe or disaster related, and that can go on the individual line items that are related to the disaster. An exception is telehealth services, do not need to have that modifier. Now, there is a modifier CS. The definition of that has recently been changed to stand for cost sharing. And that one is fairly new for us. And if you want to go ahead and go to the next slide, Jennifer, we'll talk a little bit more about the modifier CS. This was covered in the Family First legislation, which came out, and it should be applied to the 87635 and the COVID lab tests, and the medical visit that prompts the ordering of the COVID-19 lab test, and not necessarily to services after. And I went ahead and put this blurb in there from a MedLearn Matters article that came out just the 7th that said, until the public health emergency is over, you can use that CS modifier, and what it will do is it will signal to the payer that it should be covered at 100% of the fee schedule and not have a cost sharing amount for the patient. So there may be some claims that you might have to go back and resubmit, and the medical services that can prompt the lab order, it can be your office or other outpatient, your observation, emergency department, and so they did list those. So now we'll start getting into some of the flexibilities. The Stark Law waivers, huge. Those are lifted now, so you can you don't have to worry about self-referral to places that might be owned by friends or family, those types of things. They're also lifting the requirement to have fair market value for rent for equipment or services. and financial support. So if there's a physician-owned hospital, the owners can provide personal loans. And then also for physician-owned hospitals, you can increase the number of beds, operating rooms, procedure rooms. Really what CMS is wanting to do is allow you to take care of the sick people, the sick patients. All right, and then on the next slide, also there can be other benefits such as providing more than one meal or doing the physician's laundry or helping to provide childcare. Some of the group practice restrictions for services have been lifted. So one physician who may not be the physician on record for someone can go ahead and order services for another partner's patient. And also if you have like a mobile service, you can, and there's an extra site set up for that hospital without walls, the physician can rent part of the parking lot on a part-time basis, just so that those labs or radiological services can be provided. And remember, it does not have to be fair market value during this time. And so the provision of items and services related can exceed the non-monetary compensation cap. And what this allows for is if the physician wants to enter an arrangement to oversee home health patients or supervise home health agency staff, then the hospital can provide CME or their medical education to get them up to speed on new items and ways to treat patient for that specific specialty. All right. Also, Jennifer covered signature requirements. They're also extending the MIPS data submission till April 30th, and they have waived face-to-face and specific practitioner type requirements for most national and local coverage determinations. So if you can do an audio-visual visit, that will take the place of the having to be face-to-face. And also there are certain excuse me, certain NCDs that require, for this service, you have to have an interventional radiologist with over 100 hours of what have you. They're going to lift that and just state that, as long as the chief medical officer at the facility can authorize that those supervision requirements do not apply. And also physicians are part of that accelerated advanced payment program that Jennifer was talking about. And there are also provider enrollment hotlines. So if you have questions, feel free to reach out to those hotlines as well. All right, and the next slide. All right, now one thing that's good is that the provider can provide services from home, and they do not need to update the place of service on file. And the physician does not have to put their home address as the place of service. Just go ahead and use your office address. And so you can bill and contract with any auxiliary personnel to provide incident to services and bill for those. So you can stretch yourself as much as you need. And the hospital admissions can be done by advanced registered your nurse practitioners. And they're also waiving some licensure requirements where the physician or the advanced practitioner does not have to be licensed in the state where they're practicing. For Medicare purposes, they do have to be enrolled with Medicare, and then they do need to be licensed in the state where they're enrolled with Medicare, but they can cross borders and practice in other places. All right, and then for the frequency limits are being lifted for many of the telehealth services. but the hands-on visits that are required for your end-stage renal disease or the hospice and your inpatient rehab facility visits can be audiovisual. And one thing that is, I think, huge is that the direct supervision can now be a virtual presence, and that's an audiovisual presence. So the physician supervisor does not have to be in the room or the office suite, but as long as you can, as long as they're there, audio, video, that's acceptable. Now, teaching supervision requirements has also been said that that can be virtual. The exceptions are the surgeries, the endoscopies, those high-risk areas. Also lifted are the residents, the moonlighting. They were kind of restricted to the outpatient setting. Now they can moonlight on the inpatient setting, which means that they cannot be counted towards their GME. And the physician does not need to physically be there during the major provision of the services. They can review and sign off at a later date. Also, the homebound definition has been broadened. So homebound does not mean someone who is under self-quarantine and staying home. That it has been broadened to be someone who may be clinically compromised or more susceptible to catching the virus, and or someone that may be suspected or confirmed of having the virus. And so there is, so the physician can just document that this person is now going to be considered homebound, and that opens up some of the home health benefits should you use those. And then in some of the services where it says that the patient, for this is for an established patient, that is removed, so you can see patients that are new and still use some of those CPT codes, and we'll take a look at those. There's been a huge update to the telehealth codes. I've got a link to the services. If we have time, I'll pull up the spreadsheet and show you some of those. Those are temporary. There have also been some provider updates for those. The sad thing is that the physical therapy services have been added, but therapists are not considered appropriate as a distant site practitioner, they're called. So that can cause some issues. The evaluation and management code selection is going to be something very similar to what's coming for 2021. So it can be based on time or medical decision making, not necessarily the history and exam. And so, and remember, this is just for Medicare, so you'll have to check with the payers if they're going with that. And that audio video can take the place of a face-to-face requirement. But CMS has been very stringent in stating that if it's audio only, you have to use the audio services. And so some of the services that you can provide, and these are not necessarily totally telehealth visits, but they are available for you. So we've got the 99421 through 23, which is your online digital evaluation and management service. And even though the description on these stated it's for an established patient, during this time it does not need to be an established patient. All right, and then we also have some online services or the virtual check-ins, like the G2010 and the 2012. And so this can be when you have like a portal situation where the patient can reach out and say, hey, I'm not feeling so good. and my symptoms are these. Someone can review that, and the doctor can say, or the nurse practitioner can say, you know, hey, what are your last few blood pressure readings, or, you know, what's your blood sugar? You could even upload a picture of a rash or a mole for your dermatologist. So that's what these services are for. And then we have the telephone services. So even though this says for an established patient, these can be now used for non-established patients. The difference for the between the 99441 through 443 and the 98966 through 68 is that who can provide evaluation and management services versus an assessment and management. So the physicians and nurse practitioners and PAs can do the 9944 services, where like your physical therapist, your clinical psychologist, and your registered nurse can do the 989 codes. And so I'm not sure how CMS is going to take into consideration, but during some of the open door forum calls, people have brought up that, you know, many patients don't have audio video capabilities, or the internet is so poor in the area that they're not able to establish a video connection. And so they're forced to use telephone service codes. And so CMS is taking that into consideration. And so we're not sure if they will, you know, change that requirement. All right. So telehealth services. First, you need to state find out, is this telehealth? So CMS is saying use the place of service that would occur without the public health emergency. So not everything is going to fall into being a telehealth service. And then use the place of service. The O2 for telehealth would be traditional telehealth. But if your patients normally come into your office, you can use the place of service 11. You know, if the doctor usually goes to the patient's home, then you can use 12 for home, 31 for skilled nursing facility. Now, one of the questions that did come up is, you know, if the patients and the practitioner are on the same campus, but the visit is done by audio or visual, that would be considered a face-to-face and does not need to be considered telehealth. So I just wanted to then bring up some of the modifiers. So for the service, you've got 95 for the CPT code. Critical access hospitals will use the GT modifier here. And then if you were doing some of the stroke evaluations, that's your G0. But on these, you do not need to report the modifier CR. All right, now the appropriate telehealth providers, I've kind of divided that between who can provide evaluation and management services and those who are not able to provide E&M services. And then there are some other limits. For example, your physical therapists and occupational therapists are on this list. And another issue is that they're also not able to provide the physical therapy or occupational or speech services, but they can provide other services. So on the next slide, I just have some different cautions that, you know, they are provided for some telephone services, but that means they also need to be submitted on the 1500. CMS is hearing an awful lot about this, and they're stating that they're not quite sure how much wiggle room they've been given within the CARES Act. And so they're evaluating that. And so we expect that there will be some more changes coming out. All right, so for telehealth, you must use audio-visual. Audio only is considered telephone, not telephone health. You know, so if you do have some of the elderly patients that are not able to connect, it is telephone only. And then if they're same place, same facility, but not face-to-face, you can bill that as a telehealth. All right, and then the next slide. Okay, so in a nutshell, your claim is going to need your CPT and HICS code for the service, your place of service, any modifiers, the provider's place of service, and that means also that's when the patient and the provider are not in the same place. The expanded services, I've got a list here, emergency department, psych and neuropsych testing. Let's go ahead and so I mentioned that the evaluation code selection can be based on time or medical decision making. And time is all of the data on the encounter. You do not need to use history exam, and so the interim final rule did say use the time from the calendar year 2020 Medicare physician final rule. They were not changing the definition of medical decision making or the MDM, so it's still low, straightforward, etc. So I did go out and get the median times for the time selected. So here's for your new patients, and then the following slide is for your established patients. And then we also have your remote physiologic monitoring. Now this is going to be, you know, for your flu or for COVID monitoring. You know, this could be pulse ox or temperatures. It also includes when you need to monitor blood pressure or glucose monitoring. You know, so what can be transmitted from a remote place of service, you know, so you have to have the specific equipment that goes along with that. And, you know, versus the patient logging into your portal and providing that information would be the differences between remote physiological monitoring and the online services. So, and then the last slide that I've got here just shows the last of the remote monitoring codes, and then we go into the references. So I think we've got plenty of time left for questions.
We sure do. Wow, that was great, both Jennifer and Ardith. Such awesome information, especially at this time right now. I do want to remind everyone that we will go a full hour with this, but if you have submitted a question and we do not get to your question live today, please rest assured that we will include it within the FAQ document, both the question and the answer, and send it out to all attendees. So first question, can you tell us about using modifier 95 on HCPCS code Q3014?
Okay, the facilities, that is for your originating site fee. The 95 is usually for the professional claims, and the GT is for the facility claims. And I will make sure that I've got that in the when we send these back out.
Okay, great. What about new allowances made for PT, OT, SP? Those are those facility employees?
Well, if for the physical, occupational, and speech therapy, it's for what's billed on the 1500, which is your professional claim, and that would need to be done by the doctor, your MD, DO, ARNP. If it is provided by the hospital, there's nothing, because there's no way to really capture that service. But that is under discussion by CMS, and I'm not sure, and I don't have any more guidance on that.
Okay. Does the DR condition code and the CR modifier have to be on all the hospital claims?
No. For the DR condition code, that is when all of the items on the claim are related to the COVID emergency. And to me, I would think that if your patient is there, everything on that claim is going to be related to the emergency. So that would apply to someone who's, coming in with your, like the cough and shortness of breath and those types of things. So you're treating them for the COVID. If someone has appendicitis and is coming in, then no, that would not need to have the disaster related condition code.
And Ardith, can you, because there is some wiggle room there, right? I mean, it doesn't necessarily just have to be COVID patients, but it has to be COVID related in some way.
Right. So if you have a patient that comes in with appendicitis, but you're treating them on, a different floor because just because you want to keep the COVID patients quarantined from the general population, then that could be an instance where you would then put the DR on the claim.
Yeah, we've got, this is all just, it's all new, and, even patients that aren't coming in for COVID could, in certain circumstances, be impacted by the COVID, like Ardith said, moving around and stuff. So please document, because that's going to be what saves you if you're doing anything slightly irregular. Make sure it's in the record.
Okay. Our facility is providing drive-through clinics for testing. Our clinic physicians refer the patients to the testing site, and they come to the site just for the test. To confirm, in this scenario, would we charge a G0463 to account for the specimen collection?
Yes, you can absolutely in that case, because you're not providing an E&M at that point in time that it would be included in. So yes, you can use that to capture your supplies and time and everything else.
Okay, great. Can you charge U0002 if an amplified probe technique was used, since most payers are recognizing the U0002 as opposed to 87635?
Yeah, again, that's kind of a payer-to-payer thing, but I have not yet found, and I've been looking at a lot of them. Most of them are going to accept either or right now, because they don't want to be imposing any more burden on hospitals to, okay, for this payer I have to put a U, for this one I got to put the 8. Basically, CMS said they will accept either one, although the 87635 does have some restrictions on the type of methodology that can be used. But in that circumstance, you should be able to use either one for most payers.
Okay, great. Can you review the new CS modifier for outpatient hospital claims?
Yeah, and I might let Ardith chime in here. I know that basically what that modifier is going to do is waive the patient portion, the co-insurance and whatnot, so that Medicare pays 100%. Did you have anything to add to that, Ardith?
Well, I read the family the family first coronavirus stuff this morning. And it is also expanded to be not just Medicare or Medicaid, but other insurance payers are supposed to also adjudicate those claims at 100% of their fee schedule.
Right, and that is for the testing and the visits related to COVID.
Correct.
Okay. Are facilities allowed to charge Q3014 for outpatient departments of the hospital, such as oncology?
Well, that's kind of a, I might need some clarification on that question, because I think what they're asking, and remember the Q3014 can only be used if the patient is at your facility. So it would have to be, it could be used if the patient is sitting there, and I guess that means that the physician is remote and is, yeah, we might have to do some more research on that question. No. And whoever asked that. Oh,
you're correct. You're correct. So if the patient is there at the facility and is then having a visit with their doctor, then it is appropriate to bill the Q3014. If the doctor is at the hospital and is calling the patient at home, then no, you're not able to.
Yeah, we might need, I'm not sure who wrote that in, but if there's any clarification as far as the exact scenario you're looking for, that might be helpful.
Yeah, because that scenario was covered in an open door forum call with CMS yesterday.
Okay. All right. Can physical therapists that are billing under the hospital enter any type of charges for telehealth or telephone visits? These would be billed on a UB.
Unfortunately, no. It would only be recognized if it can be submitted on a 1500. And so that can be an instance where it would come in handy for a physician to contract with additional providers to have those services done incident to and submit those claims on a 1500.
Yeah, remember again that there's really no cost to a facility that would be billed on a UB for telehealth other than that site originating fee where appropriate.
Okay, great. Here's a good one. What's the difference between e-visits and telehealth?
Oh, that is,
you're the expert there.
Well, the e-visits are not, they were available for use even before they were added to the telehealth site. So you would not necessarily have to have been to meet criteria for telehealth to be able to do the e-visits. You could have been doing those before the public health emergency. And so it's just, it's a online digital evaluation and management. So that would be where you were, communicating through the portal with that established patient, kind of going back and forth with, okay, how are your blood sugars today? Any chest pain today? Those types of things, kind of back and forth with the patient. And the time is based on the cumulative total time for 7 days.
I believe those have to be patient initiated as well.
Right.
Okay. At our office, we have a registered medical assistant who works with our nurse practitioners. She responds back to the patient's messages in the patient portal. Can we bill a 98966, 98968 for her?
Yes.
As long as it's patient initiated, correct?
Right. Well, those are the telephone assessments.
Oh, the telephone assessment.
Yes.
Sorry, I don't have my book right in front of me.
Yeah.
Okay, great. I understood the IFR to say the provider should report the POS where the patient would have been seen. How would the provider report both the patient and provider's POS on the claim?
If you would, if the provider normally sees the patient in the office, then use the place of service office. So it's, if you pretended like there was no public health emergency, where would your provider be seeing that patient? And that's the place of service. And so you don't have to worry about saying, providing the address of where the patient is. Well, that should be on the claim form anyway, and having, you can still use the office billing location that you normally do. You do not have to have the physician's private residence on there.
Okay. All right. Can we as a facility bill therapy on a 1500 claim form for telehealth or e-visits?
That's going to depend on how your contract is set up with CMS.
Yeah, very few black and white answers here.
Yeah, unfortunately.
Okay, does someone have to test positive for COVID to utilize certain condition codes?
Certain condition codes. I assume maybe they're talking about the new, like CR type stuff. And I think we kind of already covered that no, so I'm assuming, it's dangerous to assume, but I think what that person is asking is a patient comes in suspected COVID and it turns out not to be, or they don't get a positive test, in which case you wouldn't be coding it with U07, but that would still be, that patient has still been treated, at least initially, as though they had COVID, so you would still be using the condition code for that claim.
Okay. Is it appropriate to report G2023 at a drive-through testing facility operated by a hospital or a clinic, even if we are also charging for an E&M and or performing the lab tests?
No. That's a big no. No, you've picked up your specimen collection in another way, and you should be picking up, if your hospital lab is performing the test, you should also be reporting either the U code or the 876 code.
Right. The G2023 and G2024 are for an independent lab technician who is going to the patient's home or skilled nursing facility to obtain the specimen. And there are some specific regulations around that in the claims processing manual in Chapter 16.
Wow, it's amazing to me how much both of you know into the detail. Can you give an example of using modifier GT? And if the doctor is in our hospital cancer center, can you bill the Q3014 when the patient does not come to the facility?
I'll answer no on the second one, and I'll let you go with the example of the GT modifier. No, the patient has to be in the hospital to bill that Q3014.
Right. And then the GT modifier is used by critical access hospitals that do method 2 billing. And so in that instance, on the professional services are going on the UB form, and so you would apply, the CPT code like the 99214 with the modifier GT. Where if for a normal physician reporting, if you were billing on the 1500, you'd use the 99214 with the 95 modifier.
Okay. All right. I just want to take a quick second to remind everyone, within 5 business days, you will receive an email. You will be getting a link to access an FAQ document, which will include all of the questions, whether we went over them live or not. It will include all of the questions submitted today with answers to each of them, as well as a link to download the presentation and a link to the live recording. So I just want to reiterate that that will be provided to you via email within 5 business days. All right. Next question. Explain the difference between modifier 59 and GT, please.
I'm sorry, 59? 95, right?
It says 59, but you know what? It could have been transposed. So we'll go with 95 and GT, please.
And I think we kind of already covered that with the previous question, but again, we'll put more detail in the written response.
Okay, great. Can a facility charge both the G2023 for the specimen collection and the lab test?
We kind of just covered that as well, that G2023 is probably not appropriate for the facility. That is for an independent lab technician going out and collecting a specimen. So more appropriately, I don't know their specific situation, but it's probably going to be a low-level clinic visit for that.
All right. Referencing behavioral health, can we bill for telehealth or video visits for group therapy?
Yes, that is one of the new codes that was added to the telehealth list. So the 90853 is on the telehealth list temporarily. So yes, you may. And also added on there are some of your opioid treatment disorder, the new codes that they have for that opioid treatment use program.
Okay. All right. This is going to be the last question that we go over live today. But again, rest assured that all the questions that were submitted will be answered and provided to everyone attending today's webinar via an email within 5 business days. So the last question for you ladies. I listened to 2 CMS town hall meetings this week. They have waffled back and forth about PTOTSC being able to do telehealth. One said there are codes, but an MD has to provide the service, and the other town hall said no. Neither independent nor hospital-based PTOTSC can provide telehealth. What is your take?
Well, as it stands right now, the PTOTSP services must be provided by a physician, but not a therapist.
There could be some contracting, though. You could get some.
Right. And there is a possibility that they will be changing that. So unfortunately, the changes are hot and heavy. It was also asked that, you know, can the facility bill the G0463 for an E&M level for these services, and they would not touch that one with the 10-foot pole. They said, you know, please send it in. And, you know, when there's split billing is going on for those office visits. And so I'm hoping to get some really good information from the response for that one. And we'll be sure that when I find that I will send it out.
Yep. Just to be clear, though, I don't think at this point I don't think they've waffled any. They've said no, 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 but they have continually said that they're going to look at it because they're hearing that a lot, that physical therapists should be able to provide services. but as of now, they cannot.
Okay. All right. Well, once again, thank you to everyone who joined us today. We understand during this unprecedented time, our schedules are extremely busy, so we want to be super sensitive on the timing today with this webinar. So we're going to go ahead and end today's webinar. Thank you for joining. Thank you, Jennifer. Thank you, Ardith. I do want to mention that we will be sending each of you a link to complete a very short 3-question survey once we wrap up this session. I do ask that you please take 2 minutes to complete it. This is the only way we're able to measure the effectiveness of the content we're presenting. And also, it serves as a purpose for us to capture additional topics that, that the industry is in favor of us presenting or looking a little bit deeper into. So as mentioned, we'll be sending you an email with an FAQ document, a link to the live recording, and a copy of today's presentation. If you'd like more information on what you saw today, or if you need additional pointers and you're a current VitalWare client, please feel free to reach out to your account manager. If you're not, you can reach out directly to me at events@vitalware.com and we'll respond as quickly as possible. Make sure you stay up to date with all of our future webinars. Follow us on our LinkedIn page. Also, visit our website under the reference tab, and you'll see all of the webinars that we have listed for the future, as well as past webinars. You can view the live recordings for those. So once again, thank you so much for joining us. Thank you, Jennifer. Thank you, Ardith. We appreciate your time. Have a great rest of your afternoon.
Bye-bye.